This is Ilan Timor recording a lecture on adnexal masses. It's a collaboration between Dr. Timor, myself, and Dr. Ana Monteagudo. We do not have any relevant financial relationships. My learning objectives is outlined here. I think that after completing this presentation, you will learn to understand the technical aspects of transabdominal and transvaginal ultrasound probes and effectively use them to characterize sonographic adnexal features on the road to the clinical diagnosis. You will also be able to recognize the most frequently occurring adnexal pathologies using grayscale, color, power Doppler, and maybe 3D ultrasound techniques. And lastly, to use the most advanced scoring systems to distinguish benign from malignant ovarian tumors. I will not read the lecture outline. You can study it if you bring up the lecture. All of them are on the top of every single slide. As for the introduction, I will talk first about scanning for adnexal pathologies, which is the hardest gynecologic scanning task, because you must arrive at a conclusion, and you have to use primarily transvaginal sonography, but you can and should at times combine it with transabdominal sonography, which will help you. You have to use a variety of transducers for depth, color, power Doppler, and finally maybe employ 3D ultrasonography. Remember, not all masses are ovarian, and I have a very important message to you. Take a good history. Do a bimanual pelvic exam before as well as after the scan to confirm the ultrasound diagnosis. And ask for a menstrual history. Type the patient's name in the appropriate place in the ultrasound machine. I repeat, in the reproductive years, physiologic as well as pathologic processes are driven by the menstrual cycle or by therapeutic or pathologic hormonal stimulation. Know the day of your patient's first day of the cycle. Mark the last menstrual period on the screen. Find the control that leaves it on the screen, even when you freeze and unfreeze images. Judge every ultrasound finding, ovarian, endometrial, and others, as a function of the day in her cycle. And in menopausal patients, enter the last year of her period. Let's talk about general and technical aspects, and one of them is that the most efficient pelvic evaluation is by using transvaginal ultrasound probes. If the bladder is full, you may want to do first a transabdominal scan and empty the bladder. Vaginal probes operate at high frequencies. Their most effective scanning depth is 2 to about 10 to maybe 12 centimeters. They accommodate all kinds of features such as Doppler, harmonic imaging, and 3D. Use the sliding organ sign, which is generated by the intermittent pressure of the vag probe, moving the cervix, ovaries, uterus back and forth to evaluate their movement relative to the pelvic floor and or each other. It is extremely useful to diagnose or to rule out pelvic adhesions. It is even more important in patients with infertility, endometriosis, or suspect for frozen pelvis. I'm using the sliding organ sign, and you can see I'm moving the ovaries with the vaginal probe, the right and the left ovary, which are moving above the great vessels. You should record the mobility or fixed nature of pelvic organs. Lately, the ultrasound machines can record scanning sequences using two kinds of features. On the fly, which is when you click, it records going forward until you freeze. Or you can see the retro view, and there where you click, it records the last 10 seconds of the live scan. For example, a structure just seen before and you want to immortalize it. Use them to record the mobility, the sliding or fixed nature of pelvic organs, and add credibility by this to your report. Acquire also sweeps of the adnexal that you can review later for maybe missed structures. Before you do the actual scan, even though it's not strictly the adnexum, on the way in, look at the bladder and the cervix. By the way, adnexum is singular and adnexae is plural. Let's talk about the normal ovary. The normal ovary is best imaged by transvaginal sonography. At times, transabdominal can help if the ovaries are really above and high up above the pelvis. In the reproductive years, it is easy to see follicles and the corpus luteum and their sonographic markers. Definitely you can see the pictures that I showed you. They live close to the hypogastric vessels. So image the hypogastric vessels, you will find the ovaries. The follicles of ovaries are important because they have one or more during a normal cycle, and they may reach a size of 2 to 2.5 centimeters. Please, please don't call them cysts or follicular cysts. They are follicles. Therefore, call them simply follicles. Remember that in the secretory phase of the cycle, you have to look for the corpus luteum using color Doppler. And that can be seen by grayscale, color, or power Doppler. And they should definitely be easy to recognize if you turn on the color better than with grayscale. Let's talk about the postmenopausal ovaries. I think everybody will have a little problem finding them. They are harder to find. They don't have follicles as markers, so you have to linger on the adnexal and look for hypoechoic, 1 to 3 centimeter structures amidst constantly moving bowels. So linger a little bit there and you will definitely be able to see these tiny anechoic structures and examine them with grayscale as well as with color Doppler. What do you look for when you look for ovarian pathology? First of all, the appearance, whether it has bizarre shapes, mixed components, the size, is it uni or bilateral, do you have fluid around the ovaries or the uterus, motion tenderness and vessels, and definitely look for mobility, and I showed you that before. When these are documented, the next step is look at the vascularity. The vascularity can be defined by looking by color Doppler and power Doppler. Look for their qualitative appearance, their location, whether they are central in the ovary or peripheral, amount of the vascularity, that's basically subjective, tortuous appearance, changes of caliber, anastomosis, and lakes. If seen, you can do flow measurements, but we lately do not really use the resistance index and pulsatility index, as well as the peak systolic velocity. Lately, we use the IOTA system, determination of the color, and I will talk about it later. You look at the general appearance. Are they solid? You can see that hyperechoic nodule there. Are they hypo or hyperechoic? Are they cystic without a solid component or with a solid component in it? And whether they are uni or multilocular. Keep in mind all these. You should also now concentrate on the internal echo structure, which may be again anechoic or hyperechoic, septated or non-septated, echogenic, or low-level ground glass appearance, like in an endometrioma, mixed echogenicity with a shadow in it, as you see there, and whether it's reticular in appearance. Look also at the wall structure. Is it thick? Is it thin? Does it have inner mural papillae or blood vessels in them, as depicted by the arrows in the two lower pictures? If you see inner wall papillae or nodules, apply power, and I say again power, not color Doppler, because power Doppler is more sensitive, with the highest possible sensitivity to detect even the smallest blood vessels. There are three kinds of papillae that I usually look at. Hyperechoic papillae with no vessels, with shadows. And these are basically benign cystadenofibroma, and that's the typical signature of these benign cystadenofibroma. Then you have the hypoechoic papillae, which have smooth, rounded borders. They have vessels and do not shadow. And these are very typical when you see with the appropriate history, decidualized endometriomas in pregnancy. And the third kind is the hypoechoic papillae with irregular borders, vessels in them, do not shadow, and these are very suspicious of borderline ovarian tumors or frank epithelial or other types of cancer. Let's see the significance of papillary formations in the ovary, which I will talk a lot more later. But there is an agreement between Europe and the USA that cysts with small hyperechoic papillae without blood vessels, these are benign and can be followed by periodic imaging. And you see the papillae that I'm talking about. On the other hand, there is also agreement that cysts containing papillae with blood vessels are suspicious for malignancy and should be removed. And there is a very good example of a solid component with a central blood vessel in it. Let's mention polycystic ovaries, which are easy to spot because they have a multitude of small peripheral follicles under their surface. There are usually more than 12 of them. They are smaller than 10 millimeters. And the size of the ovary is usually at least almost 3 times the size of a normal ovary. They have a hyperechoic hilus and rich hilar blood vessels, as shown in the 2 color Doppler pictures on the 2 sides of the text there. Ovaries are usually larger than 12 milliliters in volume. Paraovarian or paratubal cyst, that's a very frequent finding. The important thing is, as you see it in the upper left picture, that you have to see the normal ovary on that side. They are usually thin-walled, smooth-walled, anechoic. They are usually unilocular, as you see it there, highlighted by the yellow circles. If you then push these structures, you can see clearly that they move apart from each other. But again, make sure that you see a normal ovary when you see that cystic structure. So I will talk about the detailed pictorial presentation of ovarian findings, normal and abnormal. However, before that, I want to say that there is a new international consensus panel that issued a report on adnexal masses and voiced their management recommendations. The content of the following slides show the results of the agreed upon features of the adnexal. I will incorporate the consensus panel's guidelines and diagnostic criteria on the ovary in this lecture. And after each ovarian entity, benign or pathological, the next and following slides will show the evaluation and recommendations of the consensus panel in a special yellow box with a box around it. So let's talk about the non-neoplastic ovarian cyst. And they can be functional, follicular cyst, corpus luteum, theca-lutein, and non-functional, serous, corpus albicans, and endometrioma. Except the endometrioma, most resolve and do not need surgical treatment, provided they do not twist. If the diagnosis is in doubt, scan the patient in the next cycle on days 5 to 9. Let's talk first about the follicular cysts. They can grow up to 4 to 5 centimeters, sometimes even more. You can see them on the 2 pictures on the right. They have smooth wall, unilocular, and they do not have any disturbances on the wall inside or outside. They have no papillae. They are lined with flat granulosa cells, circular blood flow around the wall, almost never malignant, and no additional information can be gained if you do an MRI or if you do 3D ultrasonography. These resolve and no surgery is needed provided no rupture occurs and no torsion exists. Here is what the consensus guidelines say. Almost certainly benign, round oval configuration, anechoic smooth, no internal components, avascular, posterior, acoustic pseudo usually exists that I don't see on this picture, but usually you can see that. In the menopausal woman, a cyst of 3 centimeters or smaller is usually physiologic, representing follicles, whereas 3 to 5 centimeters cysts are typically physiologic, functional cysts. What about simple cysts? They are not precursors of cancer. They present minimal risk of malignancy and can be followed by serial ultrasound, thereby avoiding the morbidity and cost of surgery. The corpus luteum, that is a very important structure in the female pelvis in the reproductive years. You can see them with grayscale or color, as you see them in the 2 pictures. They grow up to about 3 centimeters, sometimes more. They have thick wall, they are unilocular, they do not have papillae. However, they are filled with interfaces, mesh-like texture, bizarre forms, shapes created by the clot as it shrinks and it lyses. There is abundant blood flow in the wall and around them, also called ring of fire. They regress. They don't need any kind of treatment. They may be slightly larger than 2 and 3 centimeters, and they may have a threatening appearance, but do not call them complex masses or cysts, because they are hemorrhagic corpora lutea. The consensus says that you can have several kinds of them, and in the premenopausal woman, the classic features: fine reticular pattern, composed of interdigitating fibrinal strands, do not traverse the entirety of the cystic lesion, they say. They represent bleeding into a follicle after ovulation, and they are always avascular in them. They have peripheral rim of vascularity. I said that before, the ring of fire. And they sometimes show clot retractions with the development of a concave margin and the progressive decrease in size. They help confirm the diagnosis. Here are the areas. Now, it's very important, when you see a reticular pattern and you suspect a corpus luteum, push that little cyst and see whether it jiggles, and that is a very good sign that this is a clot formation within that cyst. And I also warn every time I give this lecture, before embarking upon descriptions and definitions of ovarian physiology and pathology, remember that saying the word cyst to the doctor or the patient, or including it into an ultrasound report, for most, if not all, obstetric and gynecologic OB/GYN practitioner, it implies pathology. Therefore, do not use the word cyst. Describing a follicle or a corpus luteum, simply call them follicles and corpora lutea. The theca-lutein cyst is the special benign multiloculated septated cyst. They can achieve large sizes, 5 to 10 centimeters. They have no papillae, and in fact these are hyperstimulated ovaries, and you can see here when you do a typical FSH induction of ovulation, you have multiple follicles. If you have a clomid-induced ovary, you have usually 1, 2, or 3 larger and fewer follicles. They may occur also in diabetes, molar pregnancy, and hydrops fetaris or hormonal treatments. They resolve. No treatment is needed if no rupture of torsion occurs. Here is a good example of theca-lutein cysts in an early pregnancy, depicted in the 3 pictures. Non-neoplastic ovarian cysts are the most common cysts, and the endometrioma represents them, one of them. They are rarely septated, homogeneous, low-level echo field, no vessels, may be large, up to about 10 centimeters. MRI here is pretty useful, detecting well blood, They rarely can become malignant, and watch out for blood vessels and think of endometrioid cancer. At this point, test for adhesions, because usually they are amidst a patient who has endometriosis. They do not resolve, and most need surgical treatment. MRI, as said, is useful. The consensus says almost the same. Look at the pictures. They depict exactly what I said before. They have low-level echoes, avascular, thick-walled cystic masses, commonly also multilocular. They have high hyperechoic wall foci at times, increasing the specificity of the diagnosis. It is important to ensure that the lesion is avascular with smooth septations and no solid elements. The decidualized endometrioma, I talked about it. It's a subset of endometrioma seen in pregnancy, and they have rounded, smooth papillae, and they have vessels, but they return to their normal basic character of the pre-existing endometrioma as the pregnancy progresses. Make everything possible to obtain a reliable history, previous ultrasound images, laparoscopy results. A proven diagnosis of endometriosis by the above saves surgery during pregnancy. Fibromas of the ovary, cystic or solid. The cystic have sonomarkers such as thin wall, hyperechoic shadowing mural papillae. They are avascular. The fluid is anechoic. They are mostly unilocular. Some of them, about 30%, are multilocular, multiseptated. And again, they have very thin septae. They have a very slow rate of growth, and over the years you will see them grow very, very insignificantly. Again, here are the papillae, the small nodularities, which are hypervascular, hyperechoic, avascular, and they shadow. The differential diagnosis is a simple cyst. The solid ovarian fibromas are easy to recognize because they are avascular, they shadow, they have a myometrium-like texture, and few or very few or no vessels in the stroma. They have a very slow rate of growth. The differential diagnosis is usually Brenner tumor or a metastatic tumor from the GI tract, such as the Krukenberg tumor. Here is an example of the Brenner tumor with the microscopic and macroscopic features that you can see. Solid fibromas, as per the consensus guidelines, say exactly the same, almost certainly benign. They have strong acoustic shadowing. At times, they can be confused with a fibroid lesion, however, that is related to the ovary rather to the uterus. They tend to have minimal vascularity when you apply Doppler. And here is my explanation of how you differentiate between an intraligamentary myoma and a myoma on a pedicle. You image the uterus, the mass, and apply color Doppler and see the connection between the uterus and the mass, which will establish for you the diagnosis. As far as ovarian neoplasms, they are 75% of all occur in premenopause. Of these, only about 13% are malignant. 75% of the malignant neoplasms are diagnosed in menopause. Most prevalent are dermoid cysts, cystic teratoma, and serocystadenomas. And I definitely, or everybody would tell you that size matters, since malignant neoplasms are usually larger than benign ones. Here is the cystic teratoma, also called dermoid cysts. And you see the sonography on the left with fat globules depicted on the right after the surgery. They have variable, sometimes bizarre appearances. They usually shadow, rarely have blood vessels in them. If you see blood vessels, think of struma ovari or immature teratomas. there is almost no typical or uniform appearance. They can mimic anything, and here are a variety of cystic teratomas. You see that they are shadowing. They have a hyperechoic nodule, also called the Rokitansky protuberance. And also, I would say that 3D is not particularly useful because sonography can define them pretty well. As per the consensus guidelines, they are almost certainly benign, mature cystic teratomas, and here are some of the features. On the upper left, bright echogenic nodule, acoustic shadowing, the Rokitansky nodule there, dermoid mesh, interdigitating lines and dots representing hair and sebaceous content. Here's an echogenic mass with strong acoustic shadow. They may obscure the back wall of the large mass. They are very hard to measure correctly. Always overestimate, because the surgeon will tell you that you defined it to be very small. Here is a fat fluid level with a dermoid ball, and they have these are less common signs, but very highly specific. The mature teratoma has some internal vascularity, and you can see that here. Again, we talked about this before. The benign cystadenoma, they can be mucinous or serous. And the interesting characteristic sonofeatures are that they have septae, sometimes fanning from one central area, from one point. There is no shadowing present. There is usually not too many or large solid components in them. They have anechoic serous or echogenic mucinous fluid in them. They have very few blood vessels. MRI is most of the time not necessary because you can define it pretty well with sonography. And then there are hormone-secreting tumors. They are usually very vascular. They have general clinical symptoms. Watch out for effect on target organs. And here is one of the two examples that I'm showing you. This is an intra-ovarian steroid cell tumor. It's contained within the ovary. They have small size, homogeneous echogenicity, and when you apply the Doppler, you will see a vascular ring around them, exactly as you see in corpora lutea, and definitely this also is because they are highly vascularized. They have to carry away the hormonal product that they are famous for. Rarely found. Usually they are found usually by their clinical presentation or by laboratory tests. And the second one would be the granulosa cell tumor, of which the sonographic markers have to be recognized. They are usually multiseptated, multilocular structures, but they can also be totally solid. They are usually vascular and sometimes very vascular, and usually occur in patients with high BMI. In this case, the blood flow with low resistive indices also was found. The best clue to the correct diagnosis is not the ovary, and you have to look at the next slide, which depicts basically the fact that they are having an effect on the endometrium. The slide is shown 2 slides after this. Malignant neoplasms. Basically, these are solid masses, and the consensus guidelines will say that they definitely are suspicious for malignancy, and they have an interim growth. So if you scan them with a time interval, they will show some kind of growth. Here, a solid mass was measuring 3 centimeters, and after about 8 months, it was 5.5 centimeters. which was a significant growth. This is a very good example of a solid mass with vascular component, and the consensus guideline says that it is highly suspicious for malignancy. The large solid nodule within otherwise simple cyst shows internal central vascularity on color Doppler sonography. Blood vessels in an ovarian cancer using color and power Doppler interrogation is very important. Here you can see a rich vascularity, irregular vessel, changing calibers. You have papillary vessels. They have central vessels in the amidst the ovary. They have also some lakes and anastomosis between the different vessels in them. Here is an example of a clear cell cancer of the right ovary with the IOTA score of 4. And this is the time to talk about the IOTA Coral score, which you can see are grade 1, score 1, 2, 3, and 4. Number 1 is when no blood vessels are seen. Number 2 is minimal flow. Moderate flow gives it a color score 3, and the color score 4 is given when the adnexal mass appears highly vascular and marked blood flow in it. The septations bear importance also, and the consensus guidelines say that it's suspicious for malignancy. Thickened irregular septations, as you see here, a very thin and a very thick septation. Very few smooth septations are not concerning for malignant disease. However, if they are multiple, more than 10 of them, or if they are irregularly thickened and vascular septations, they are concern for malignancy. Here is a cyst A with several smooth thin septations. When persistent, it's likely to represent benign, serous, or mucinous cystadenomas. In B, you can see a large 10 centimeter cystic lesion with multiple thick septations with low-level echoes and definitely suspicious for malignancy. You also see small mural nodules around it, and that increases the suspicion for malignancy. I come back to the granulosa cell tumor because it's important for you to look at the uterus at that time, in that instance. And the clue here is thick hyperechoic endometrium with microcystic changes, similar to cases with endometrial hyperplasia seen in about 40% of the cases. As a matter of fact, it is endometrial hyperplasia as a result of estrogen production in the tumor. They can be solid, cystic, the granulosa cell tumors, of course, solid with a spongy appearance, and entirely solid. Let's talk a little bit about scoring system to differentiate between benign and malignant ovarian masses. So there are ultrasound-based scoring systems. They all translate macroscopic pathologic features to sonographically recognizable features. All sonographic based scoring systems are looking at the same building blocks: wall thickness, septation, echogenicity, papillae, solid components, and blood supply. Some systems add size, ascites, and patient age. And again, all of them, we have talked about all of these, and you can just note that these form the base of all scoring systems. Several scientifically proven set of articles suggest that subjective evaluation of adnexal masses is almost as good as the evaluation based upon strict scoring systems. One may use morphology scoring systems. There are many out there, but however, you don't have to be. They don't have to be applied to the letter. Just understand their basic idea to differentiate benign tumor from suspicious or malignant. We pride ourselves here that we published the first sonographic scoring system, that basically was then followed by many much better ones. The Kentucky scoring system developed by Van Nagel in Kentucky, also a widely used scoring system. But lately we are trying to apply the IOTA scoring system, and the simple rules of this group, the IOTA group, are today maybe the basis of how we look at adnexal masses. The IOTA means International Ovarian Tumor Analysis, and the simple rules are the following. There are benign features, 5 of them: unilocular cyst B1, B2, presence of solid components of less than 7 millimeters, acoustic shadowing like in dermoids, smooth multilocular tumor with the largest diameter of less than 10 centimeters. These are all benign features. And then no detectable Doppler flow, of course. And the IOTA simple rules, the malignant features are irregular solid tumor, ascites, at least 4 papillary structures within a cystic lesion, irregular multilocular solid tumor with the largest diameter of more than 10 centimeters, and high color content on Doppler examination. Let me talk about the fallopian tube for several slides. It is a normal fallopian tube is almost undetectable unless it's surrounded by fluid. Tubal pathologies can be detected and diagnosed by grayscale and color Doppler and transvaginal ultrasound. The inflammatory tubal diseases are the ones that you will encounter in the emergency room as well in the ultrasound suite. There are several main shapes of fluid-filled tubes, and these are oval, the pear or sausage shape, the retort shape. I will talk more about this with the incomplete septae, and the serpiginous appearance of these fluid-filled tubes. The incomplete septum is a pathognomonic feature. The septum does not reach the opposite wall, as you can see here. It results from the kinking of the fluid-filled tube. They present in acute as well as chronic cases, so they don't discriminate between acute and chronic. And they are pretty pathognomonic for the diagnosis of hydrosalpinx. The acute salpingitis is recognized by its ultrasound markers, such as the cogwheel sign, thick wall, circular vessels around it. And again, here is the cogwheel sign. That's the shape of the fluid that it assumes with thick wall around it. And you can see also low-level echogenic fluid and the color signal around the outer wall of the tube. The chronic hydrosalpinx, on the other hand, is defined by the appearance of the tube rendering it a beads on a string appearance. The incomplete septae are there in this one also. The wall is distended, thin. There's anechoic fluid, and there are fibrosed endosalpingeal folds that are small nodules on the wall, and you can see them in histology. Together, they render the tubal wall the appearance of a rosary. If identified, it is pathognomonic of chronic hydrosalpinx. Tubo-ovarian-complex, it is when you can recognize the ovary in the tube as such, thick walls, tubal fluid, ovary in the tube recognizable, and there is a cogwheel sign still recognized there. This is not a tubo-ovarian abscess as yet. When it is a tubo-ovarian abscess, then you will not be able to recognize anymore the features of the tube and the ovary. They have speckled fluid, they're usually bilateral, they are located in the cul-de-sac. This is now a tubo-ovarian abscess, and don't call it Tubo-ovarian-complex when it's not yet an abscess. Tubal cancer is rare, and it accounts for 0.3 to 1.8% of these cancers. Papillary serous adenocarcinoma represents more than 90% of these cancers. Other less common types include clear cell carcinoma, endometrioid cancer, and germ cell cancer, as well as sarcoma. Here is a typical picture of a tubal cancer. You see the elongated feature on grayscale and the colored Doppler and the laparoscopic image of the same. And again, here you see the Doppler scanning of the tubal cancer on cross-sectional image. You see the vessels around the thickened tube and the lumen, and the vessels along the outer perimeter of the elongated tubal structure. They are very rare, and again, the sono characteristics are adnexal mass, as in ovarian cancer. If sausage-shaped, thick-walled cystic area is seen, suspected. There are peripheral subserosal vessels, as I said. If mistaken for ovarian cancer, you made a good call. Here is a specimen of the same tube that I brought the picture in the upper ultrasound. Additional sites to check are the cul-de-sac, and the most frequent finding is postoperative peritoneal inclusion cysts in loculated pelvic fluid. The diagnosis should be suspected in the right clinical setting. You will see filmy, undulating strings of adhesions when you move it with your vaginal probe, and they are typical and benign. You can see them right there. And of course, you should also scrutinize the pelvic peritoneum for tumor seedings, mainly when you see fluid above it, they will outline these peritoneal seedings. I will now end with the new consensus panel recommendations. First of all, pelvic sonography should include transvaginal approach with Doppler imaging as indicated. Simple ovarian cysts are not precursor lesions to malignant ovarian cancer. However, it is crucial to perform a high-quality examination to ensure the absence of any solid papillary structures before designating it a simple cyst. The risk of progression to malignancy is extremely low. Thus, a degree of follow-up is very prudent. Real-time pattern recognition sonography in the hands of an experienced imager is currently the most accurate method characterizing an ovarian mass. Initial mass characterization could be performed either by pattern recognition or via risk model, such as the IOTA simple rules. When an ovarian lesion is considered benign, the patient may be followed conservatively, or if indicated, surgery can be performed by a general gynecologist. Serial sonography is a beneficial strategy, but there are limited prospective data to support an exact interval and duration. Fewer surgical interventions may well result in an increase in sonographic surveillance. When an ovarian lesion is considered indeterminate on initial sonography and after appropriate clinical evaluation, a second step evaluation may include referral to an expert sonologist, serial sonography, application established risk prediction models, correlation with serum biomarkers, correlation with MRI, or referral to a gynecologic oncologist for further evaluation. Here are my summaries and conclusions. Most of the time, adnexal masses carry definite sonomark characteristics and pathognomonic features, such as markers. The main sonomarkers of the commonly seen adnexal masses were described to enable a better recognition of their possible histology. Wherever relevant, clinical features helping the diagnosis were also mentioned. Where applicable, relevant articles from the contemporary literature were also quoted. Most adnexal masses can be assessed subjectively using a transvaginal probe, transabdominal if there is a large mass, an enhanced basic ultrasound knowledge, reading reviews, the liberal use of power Doppler, recognizing benign and malignant sonomarkers, and finally, if you like to use the term complex mass, describe the mass in terms of their sonographic characteristics, possibly based upon the new consensus data or the iota simple rules. Avoid the word cyst, referring to follicles, corpora, lutea. Be attuned to the issues of papillae in a cyst, their size, the number of blood vessels in them. Avoid the sentence malignancy cannot be ruled out. Use it when really needed. Use my suspicion of the structure to be malignant is high, moderate, low, none, or cannot classify. Or you can use I favor the diagnosis of X, Y, or Z as the one that you were most impressed with. And ask for a gynecologic oncologist when in real need. I hope that you got the most important features from this lecture and will use it in your residency program and after. Thank you for listening.